Assalamu alaikum. Today I'm going to discuss a topic of neuroanatomy, which is the basal nuclei. Now, this is a very important topic when we're considering neuroanatomy. So our learning objectives for today are that we are going to list the terminology commonly used to describe basal nuclei, and we'll describe the basic anatomy, connections, and functions of different basal nuclei. And we shall also correlate this basal nuclei anatomy to the clinical conditions commonly affecting the nervous system. Now, you know that the basal nuclei are also known as the basal ganglia. This is a term which has been used in the textbooks, but it is now largely considered a misnomer since the better representation of the basal nuclei is that they are the subcortical paired masses of gray matter lying at the base of the forebrain. And remember that they are embedded deep within each cerebral hemisphere. And the main function is that they are important in initiation and control of voluntary movement. Now, what are the components of the basal nuclei? Well, basal nuclei, they consist of the caudate nucleus and the putamen. Also, globus pallidus, the amygdaloid nuclear complex might be included within the basal nuclei. And functionally, remember, the closely related structures to basal nuclei are also the substantia nigra of the midbrain, as well as the subthalamic nucleus in the diencephalon. So this is a list of the components of the basal nuclei. Now, when we consider terminology, we have to look at over here that the caudate nucleus, and when we talk about the putamen, the caudate nucleus and the putamen, they are collectively known as striatum. And this striatum is actually the neostriatum. So neostriatum or striatum is the caudate nucleus plus the putamen. Now, the other thing that we have to remember is that when we talk about the globus pallidus and the putamen, they are collectively known as the lentiform nucleus. Also, the claustrum can be included within the basal nuclei. When we use the word corpus striatum, this is a larger term because corpus striatum includes the caudate as well as the lentiform nucleus, mainly the three components, that is caudate, globus pallidus, and putamen. So these are the terminologies which we have to keep in mind whenever we are discussing the basal nuclei. Now, phylogenetically speaking, that is on the basis of evolutionary development, the oldest part of the basal nuclei is the archistriatum, and within archistriatum comes the amygdaloid nuclear complex and the claustrum. Then comes the paleostriatum, which is globus pallidus. And then, as I mentioned in the table, the neostriatum is, in simple words, striatum, that is the caudate and the putamen. Now, let's discuss these different components of the basal nuclei one by one. Now, the first one is the caudate nucleus. Now, this is an elongated, arched gray cellular mass, and it is related throughout its extent to the lateral cerebral ventricle. It consists of an enlarged anterior or rostral portion known as the head, which protrudes into the anterior horn of the lateral ventricle. Whereas the body is narrow and it lies dorsolateral to the thalamus. The body posteriorly extends into a tail which passes dorsal to the hippocampus and ends in a rounded amygdala which lies rostral to the tip of the inferior horn of the lateral ventricle within the temporal lobe. Now, let's try to understand these points in a diagram. Now, here I'm showing you the lateral view of the right cerebral hemisphere, which has been dissected and has been exposed to show the position of the basal nuclei. Now, right now we were talking about the caudate. So if you follow the laser pointer over here, this is the portion which is known as the head of the caudate nucleus. Now, as you can see, the head of the caudate nucleus is present anterior in position, and it is lying in relation to this here anterior horn of the lateral ventricle. Now, this head of the caudate nucleus is also continuous with this mass, this gray cellular mass, which is the lentiform nucleus. If you recall from the table, I told you the lentiform nucleus includes the putamen and the globus pallidus. So coming back to the caudate, the head is over here present anteriorly, and posteriorly it narrows into the body of the caudate nucleus. And you can see it is closely related to this body of the lateral ventricle. Posteriorly, this body further becomes narrow, and here begins the tail of the caudate nucleus. And you can see the tail of the caudate is lying dorsal to this here hippocampus. Also, it is present dorsolaterally to the thalamus. Now, this tail, it extends inferiorly and ends in a round almond-shaped structure, which is known as the amygdaloid nucleus. And amygdaloid nucleus is lying just anterior or rostral to this here tip of the inferior horn. This here is the tip of the inferior horn of the lateral ventricle. So this gives the caudate nucleus a characteristic C shape when you observe it in the exposed specimens of the brain. Now, the other component, which is the lentiform nucleus of the basal nuclei, the lentiform word simply means lens-shaped, and we shall see that it looks like a wedge, which is present in the transverse sections. We can see the wedge with its apex directed medially. And this part lies between the external and internal capsules, which are composed of white matter. There is a slightly curved vertical lamina of white matter which further subdivides the lentiform nucleus into an outer darker portion, which is the putamen, and an inner lighter portion, which is the globus pallidus. So here now we are looking at a transverse section. If you look at the inset in the top left of the screen, you can see the level or the plane of the section that has been taken. Now this is a transverse section through the brain. And now as we are looking at this transverse or horizontal section of the cerebrum from above, we can see here are the frontal lobes, and this here area, you can see the insular cortex in this part of the cerebrum, and posteriorly is the occipital lobe. Now, coming over here in the middle section, we can see this area. You can just follow the laser pointer and I'll guide you through the parts of the basal nuclei that are visible. Well, this has section through the head of the caudate nucleus. And then over here, you can see the wedge-shaped lentiform nucleus, which I told you consists of the outer darker part, that is the putamen, and then the inner lighter portion, which is the globus pallidus. And on the inner aspect, medial to this lentiform nucleus, is this white matter, which is known as the internal capsule. You can consider it like an angle which is opening laterally. This here internal capsule has an anterior limb, the bend, which is known as the genu of the internal capsule, and then the posterior limb of the internal capsule. And medial to the posterior limb of the internal capsule, you can see the thalamus. So like I said, these are paired structures. What you see over here on your right, you can see the similar structures on the left. Also, you have to notice that lateral to lentiform nucleus, you can see is the white matter known as external capsule. So this lentiform nucleus is lying between internal capsule medially and external capsule laterally. And then lateral to the external capsule is this sheet of gray matter, the claustrum, which I told you may be included within the basal nuclei. And external to that, you can see the insular cortex. This is the area of gray matter, which is the area which is buried deep within the cerebral hemisphere. This is known as the insular cortex. Okay, so if we were to look at the prosected section, it is still the horizontal section through the brain, but in this case, it is not a drawing, it is a prosected specimen, and we are looking at half of the cerebrum from above. Then we can see that these structures are here. If you look at it closely, you can see the wedge-shaped lentiform nucleus, okay, and it has the lateral part, which is putamen. Remember, putamen is the largest and most lateral part of the corpus striatum. And medially, you can see here is the globus pallidus, and this globus pallidus is further subdivided into an outer and inner segment by medullary lamina. You can also see the head of the caudate nucleus. Why don't we also look at an MRI, an axial cross-section of an MRI of the brain? Here, when we look at these structures, as a radiologist would identify them, you can see the lateral largest part of corpus striatum, that is putamen. Medial to that, you can see here is the globus pallidus, and then this portion here is the thalamus, which lies medial to the internal capsule. Also, you can see over here where the laser pointer is present, this is the head of the caudate nucleus. So these are the structures as they are visible on an MRI cross-section. If we were to take a section which is a coronal one, as you can see in the inset in the top left, this coronal section divides the brain into anterior and posterior halves. Now, if we are going to look at the coronal section turned towards us, then we can see in this here basal region of the cerebrum, we can see the basal nuclei. And here B marks the largest, the most lateral part of corpus striatum, which I told you is the putamen. And medial to that, this here C and D represents the globus pallidus, where C is the outer segment of globus pallidus and D is the inner segment of globus pallidus. And here A represents the caudate nucleus. Whereas the area marked L and darker over here, this is the internal capsule, right? So these are the structures that can also be visible in the coronal section of the brain. As I told you before, functionally speaking, the substantia nigrum of the midbrain is also included within the basal nuclei. Let's look at the transverse section of the midbrain at the level of the inferior colliculi. So we can see over here the posterior aspect, you can see the tectum contains these inferior colliculi. And if we look at the portion which is anterior to the tectum, here, if you follow the laser pointer, is the area which represents substantia nigra. So what is substantia nigra? The word nigrum is a Latin word meaning black substance because of the pigmented neurons over here which contain melanin. This is an area of nuclei which are present in the midbrain dorsal to the crus cerebri. So this here is the crus cerebri, and you can see dorsal to it or posterior to it is the substantia nigra. And it consists of further two distinct parts. One part is known as pars reticulata, which is the ventral part, which has less number of cells. And then there is the pars compacta, which is the dorsal part of substantia nigra, and it is highly cellular. The blood supply of the basal nuclei is by lenticulostriate branches of middle and anterior cerebral arteries and the anterior choroidal branch of the internal carotid artery. Okay, so now that we have talked about these basal ganglia, we are going to look at these structures in a three-dimensional digital model. Okay, so now we are going to be looking at a three-dimensional model of the brain, and our focus is on the basal ganglia. So if you look over here and you follow the hand pointer, you can see that this is the outline of the cerebrum. And here is the anterior aspect where the frontal lobe is present. And here is the parietal lobe, and then the occipital lobe, and this is the area of the temporal lobe. Now, within this outline, you can see embedded under the covering of the massive cerebral hemispheres are these collections of gray matter, which are known as the basal nuclei. Now, as we've been talking about the basal nuclei, you can see that the part which is labeled 1 and is colored in pink, this is representing the caudate nuclei, whereas the portion in yellow, the lateral one, is the putamen. Now, before going into the detail, I would like to move this model of the cerebrum around so we can get a superior view. As we look at it superiorly, you can see that these masses are paired for each half of the cerebral hemisphere. So let's zoom in onto the caudate nucleus. And here we can see the anterior portion is the head of the caudate nucleus. And this here is the body of the caudate nucleus, which then posteriorly it tapers into a tail. And this tail, then you can see it moves behind the rest of the nuclei, and then it continues as this portion which ends into the amygdaloid nuclear complex just rostral to the tip of the inferior horn of the lateral ventricle. So this here is a C-shaped caudate nucleus, and we know that this is the arched mass of gray matter, and it follows the body of the lateral ventricle. Now, on the outer aspect, as I showed you, this orange mass, which is large, and it is dorsolateral to this area in blue, that is the thalamus. This large outer orange-colored mass is representing the putamen. And if we look at these structures from below, then on the inner aspect of this putamen, this smaller part, which is purple in color, or you could say purplish blue, this is the globus pallidus. So putamen and globus pallidus are collectively known as the lentiform nucleus. Now here is the thalamus. You can see the two thalami over here, the left and the right, and they are connected by this here interthalamic adhesion. Also on the undersurface of the thalamus, we can see number 4 is representing the parts of substantia nigra. Now, substantia nigra is present within the midbrain, and this is considered to be, functionally speaking, a part of the basal nuclei. Also on the under aspect of the thalami, this darker gray colored portion, these represent the subthalamic nuclei, right? So this was the description of the basal nuclei on the three-dimensional model to help us understand the basic parts, the basic anatomy of the basal nuclei. Okay, so now that we have discussed the basic anatomy of the basal nuclei, now we will come to the functions as well as the connections of the basal nuclei. First, we have to remember whenever we are considering the functions of basal nuclei, we want to summarize these functions, and we have to keep in mind that there are input nuclei and output nuclei. Now, the input nuclei are the caudate and putamen, which I told you before are the striatum. Whenever we say striatum, we mean caudate and putamen. So these are the input nuclei, whereas the output nuclei are globus pallidus and substantia nigra. Now, the basal ganglia, together with the cerebral cortex and the ventrolateral nucleus of the thalamus, form two parallel but antagonistic pathways, which are known as direct and indirect pathways or circuits. Now, both of these pathways, they use the process of disinhibition to mediate their effects. Disinhibition is the process in which one population of inhibitory neurons inhibits a second population of inhibitory neurons. So this is the process, disinhibition, which plays an important role in the functioning of the basal nuclei. Now here I would like to share with you this slide, and this slide is going to show us the direct and indirect pathways of the basal nuclei. Now, I would like you to follow the laser pointer over here, where first we're going to discuss the direct pathway of the functioning of the basal nuclei. Now, this is the pathway that starts over here. We can see this is the cortex. Keep in mind that those arrows which are white over here represent excitatory function, whereas the arrows which are black, they represent the inhibitory function. Keeping that in mind, we can see that the cerebral cortex, it provides an excitatory input to the striatum. And we know the neurotransmitter for this excitation is glutamate. So the excitatory input which projects onto striatum, now when we're saying striatum, we mean caudate and putamen. Now, within the caudate and putamen, there are inhibitory neurons. These inhibitory neurons then project their axons onto the globus pallidus. To be more specific, this is the internal segment of globus pallidus. So this here area also contains inhibitory neurons, which then project onto thalamus. And remember, the neurotransmitter in case of the inhibitory neurons is GABA, which stands for gamma aminobutyric acid. The thalamus will be disinhibited. So you can see this black arrow over here. The thalamus is going to be disinhibited, and this causes the increased, you see, excitation of the supplementary motor area within the cerebral cortex. So the net effect of this direct pathway is an increased excitation of cerebral cortex, and this causes, or you could say promotes, the movements. Over here, keep in mind, like I told you, the input nuclei is the striatum, that is the caudate and putamen. It is receiving the input from the cortex, whereas the output nucleus you can see over here is the globus pallidus as well as the substantia nigra. Substantia nigra has some axons which are projecting onto striatum, and these are the dopamine-producing neurons within substantia nigra. We will be talking about them a little later. Right now, we're just looking at this direct pathway, and now we have seen that this is the pathway responsible for increased excitation of the cortex. Now, the other pathway, which is the parallel antagonistic pathway, is the indirect pathway. Now, the beginning of the functioning of this pathway is also from the excitatory input from the cerebral cortex onto the striatum. Since I told you before, the striatum are the input nuclei. They're receiving input from the cortex. The inhibitory neurons project their axons, which have GABA as the neurotransmitter, in this case, onto the external segment of the globus pallidus. So globus pallidus is the input nucleus, and the globus pallidus from the inhibitory neurons within globus pallidus will now project onto the subthalamic nucleus. The subthalamic nucleus will then provide excitatory stimulus to the internal segment of globus pallidus, and this will in turn produce an inhibition of the thalamus. So because there is an inhibition of thalamus, the excitatory signals to the motor cortex will be suppressed or decreased. So the net effect of this indirect pathway is a decreased level of excitation of the motor cortex. And as a result, the unwanted voluntary movements are suppressed. This is what we are going to summarize in the next slides, what we have just discussed over here, that the net effect of disinhibition in the direct pathway results in an increased level of cortical excitation and promotion of movement, whereas the net effect of disinhibition in the indirect pathway results in a decreased level of cortical excitation and therefore suppression of unwanted movement. Also to keep in mind is the influence of two important chemicals, that is the dopamine and acetylcholine. Now, these are two very important substances present within the brain. As I told you before, dopaminergic neurons are present in substantia nigra and they are projecting to the striatum. The effect of dopamine is that it drives the direct pathway, and so it increases cortical excitation. It also inhibits the indirect pathway, leading to the same result, that is increased cortical excitation. Whereas acetylcholine has the opposite effect. Cholinergic neurons are found within the striatum, and they have the opposite effect to dopamine, that is, they drive the indirect pathway and thus they decrease the cortical excitation. Now, if we were to summarize the connections of corpus striatum, remember the afferent fibers are coming from the cortex, the thalamus, the substantia nigra, and also the brainstem. Whereas those fibers which are leaving the corpus striatum, the efferent fibers, are going to the globus pallidus as well as the substantia nigra. So most of these connections are bidirectional. Globus pallidus connections are the afferent ones, which are striatopallidal fibers, that is, they're going to the they are coming from the globus pallidus, And the efferent fibers which leave the globus pallidus are known as pallidofugal, and they're further subdivided into 4 groups. One is ansa lenticularis, which pass to the thalamic nuclei. Then the fasciculus lenticularis, which passes to the subthalamus. Pallidotegmental fibers, which pass to tegmentum of midbrain. And the pallidosubthalamic, which also pass to subthalamic nuclei. Now let's come to the clinical correlation of what we have studied. We have seen that there are 2 pathways working within the basal ganglia, and one is the direct and the other is an indirect pathway. If there is some imbalance between these 2 pathways, it can result into generally 2 types of conditions. First one is the hypokinetic disturbances. Now, hypokinetic, the name is self-explanatory. It represents decreased movement or slowed movement. This primarily occurs due to disturbance of the direct pathway, and that leads to an underactive cortex. The other category of disorders are the hyperkinetic disturbances, which occur due to disturbance of the indirect pathway, which results in an overactive cortex. So if your cortex is overactive, you would have the unwanted excessive movements, which are grouped under the main heading of hyperkinetic disturbances. Now, whenever we are talking about basal ganglia, we cannot leave out Parkinson's disease. Parkinson's disease is primarily included within the hypokinetic disturbance, although it does show elements of disturbance in both the direct and indirect pathways. To understand the importance and significance of this condition, let's just look at some stats before we go into the details. More than 10 million people in the world right now are living with Parkinson's disease. And in the world, it is the second most common neurodegenerative disease after Alzheimer's. It is a progressive neurodegenerative disorder, meaning the symptoms, they worsen over time, and the age in which occurs is usually 50 to 65 years. And men are also seen to be 1.5 times more likely to have Parkinson's disease than women. Now, Parkinson's disease, the lesion is present, remember, within the substantia nigra, where there is a degeneration of the dopaminergic neurons. And the cause in majority cases is not clear. It will be unknown, but rarely it might be associated with a viral infection. After viral encephalitis, Parkinson's disease can occur. It might also be due to the effect of certain drugs and like antipsychotics, and it also might be due to toxic poisoning. So there are different factors that have been linked or associated with Parkinson's disease. A genetic element has also been associated with this condition. Now, what are the cardinal signs? That is the main signs of Parkinson's disease. Remember, these are the cardinal signs. The first one is the tremors. If you have seen a patient of Parkinson's or heard about the patient, the first thing that comes to your mind is the tremors. So these are the patients which have tremors at rest. And the classic one is the pill rolling. You can see the pill rolling movements of the fingers. Also, there is bradykinesia, which means slowing of the movements and difficulty in initiating the movement. There is rigidity in movement as well, which can be the passive rigidity, the rigidity that occurs on passive movement of the limbs, or it can be the cogwheel rigidity, that is the resistance which occurs in segments. There are also disturbances in the posture of the patient. Also, when the patient walks, there is a disturbance of gait. Now, we will be looking at these symptoms one by one in detail. I'll be showing you the videos of patients with these cardinal signs. The expressionless face is, all you could say, the plastic face is also a cardinal sign of Parkinson's disease.
Predominantly left-sided tremor at rest, affecting the hands and feet. The tremor in the hands involves both fingers and the wrist. It is most prominent when the hands are at rest, but improves somewhat during action. This patient demonstrates predominantly left-sided bradykinesia. Rapid alternating movements become progressively slower and smaller in amplitude with repetitive performance. Bradykinesia.
So we saw these two videos. The first one showed us the tremors at rest, and the tremors in case of Parkinson's disease actually get better upon movement or when action is performed. And you also saw the classic pill rolling movements of the fingers in the patient. Then the second video showed us that when rapidly alternating movements are performed by a patient of Parkinson's disease, the patient has difficulty in performing these movements because the movements are slowed. There is bradykinesia on the affected side. So remember, this is an asymmetric disease and it can affect one side of the body. And over here, now in this diagram, I am showing you the typical posture of a patient with Parkinson's disease. The typical posture you can see is the stooped posture. And in other words, we could say the patient is unable to maintain an upright, erect posture. This develops later in the course of the disease, and also the balance is impaired. The patient can fall down, and this is the most disabling motor symptom. Okay, when we talk about the gait disorder, we know that the patients have an abnormal manner of walking, and this may include lack of arm swing. The arms will be flexed at the elbow, and one leg might be dragged. And there's the characteristic gait, which is known as the shuffling or festinating gait, in which the patient takes small steps, and also the patient hurries in his or her movements.
This patient takes slow shuffling steps and has trouble turning. She has flexed posture of the trunk and arms with reduced stride length and slow speed. Speech is
Okay, so keep this in mind that when we were talking about the cardinal signs of Parkinson's disease, it is not necessary that all of these signs would be present within one patient, but a different constellation of signs and symptoms are present, and either of these are going to be there in this patient. And there are some other signs and symptoms like dysarthria. The speech of the patient becomes monotonous and monopitched. There is difficulty in eating and swallowing, and the handwriting is smaller in size than normal, and this is micrographia, another typical sign of the Parkinson's disease. Now, when we talk about the treatment of this disease, then we have different things to consider. The gold standard is levodopa, which crosses the blood-brain barrier and then is converted into dopamine in neurons of basal nuclei. So dopamine cannot be given directly to the patients of Parkinson's disease since it is unable to cross the blood-brain barrier. So its precursor, dopa, is administered, which then crosses the blood-brain barrier and is converted into dopamine within the neurons of the substantia nigra. Also, the drug selegiline has been given. It can be given because it inhibits the enzyme monoamide oxidase, the enzyme that destroys dopamine. Anticholinergic drugs can also be given to patients of Parkinson's disease, as they will inhibit the effects of acetylcholine on the indirect pathway and cause relief of the signs and symptoms. Some other advanced techniques which are based on trial, or experiment, have also been used, in which you can embryonically transplant these cells, these dopaminergic neurons of the substantia nigra. But these are the new techniques which are still under trial mostly. Now let's talk about the hyperkinetic disorders. Now that we have discussed the Parkinson's disease, which was mainly considering, we were considering hypokinetic disturbances, let's look at the hyperkinetic disorders related to the basal nuclei. Now, when we're talking about the hyperkinetic disorders, there is Huntington's disease, which we should consider. The Huntington's disease occurs due to a degeneration of the GABAergic neurons in the neostriatum, that is within the caudate and putamen. So this is going to cause an atrophy of the head of the caudate nucleus. And this is autosomal dominant inheritance in pattern. And over here in this disease, there are going to be the clinical manifestations, which are chorea and athetosis. Now, first, let me talk about chorea. When we say chorea, we mean that there are going to be multiple random jerky movements, which are rapid jerky movements. And athetosis means the slow writhing movements which will appear in the patient. There could also be personality changes and dementia. So treatment of Huntington's disease is that you'd give antipsychotic agents, benzodiazepines, and anticonvulsants. Also, there is the condition which is known as hemibolismus. In case of hemibolismus, the part of the basal nuclei which is affected is the subthalamic nucleus. There is hemorrhagic destruction of the contralateral subthalamic nucleus. So such patients, they exhibit the wild flinging movements of the limbs, which is known as hemibolismus, and it typically occurs in patients who are hypertensive. Another disease to be considered when we talk about basal ganglia is the Wilson's disease, also known as hepatic lenticular degeneration. In this disease, there is accumulation of copper in the liver, the brain, and the eye. The eye exhibits the Kayser-Fleischer ring, which can be helpful in diagnosing this disease. The lesion in this case is especially within the putamen. There will be tremors, and Parkinsonian symptoms can also be there, and also the cirrhosis of the liver because of accumulation of copper in the liver. The treatment is with penicillamine and zinc acetate. Another condition, clinical condition, which is related to the abnormality in the basal nuclei is Tourette's syndrome. In a patient of Tourette's syndrome, there are motor tics and vocal tics. It means the uncontrolled sudden voluntary movement, and also this includes often obscene or inappropriate vocalizations. And the treatment is with antipsychotic agents. Another symptom that I would like to mention is dystonia, which can occur when we are talking about the imbalance between direct and indirect pathways of basal ganglia. Dystonia means slow, prolonged movement, typically involving the truncal musculature, that is the musculature of the body in the midline. This often occurs along with athetosis. It can include blepharospasm, which is a contraction of the eyelids, and spasmodic torticollis, in which the head is going to be tilted towards the shoulder, and writer's cramp, in which there is a contraction of the muscles of the hand and the arm on attempting to write. So these could be different presentations of dystonia. Okay, so now that we have discussed the functions of the basal nuclei along with the basic anatomy, let's assess our knowledge by looking at a few clinically relevant scenarios. Now, here is a scenario in which a patient has a stood posture, shuffling gait, and a tremor in the fingers at rest. Which part of the brain will show neuronal degeneration? This is the mesencephalon. You see, the mesencephalon, also commonly called the midbrain, is the area which contains substantia nigra. And substantia nigra, has the dopaminergic neurons, and it is the degeneration of the dopaminergic neurons that produces these characteristic signs in a patient, which is the patient of Parkinson's disease in this scenario. Here is the next question: which neurotransmitter may be inhibited pharmacologically to reduce the effect seen in the patient of Parkinsonism? We know it is acetylcholine because acetylcholine is going to counteract the effects of dopamine. So if there is already a deficiency of dopamine in Parkinsonism, it would help the patient if we would inhibit the effects of acetylcholine. Here is another clinically relevant scenario. A hypertensive patient suddenly develops violent flinging involuntary movements in an upper limb. The patient is able to suppress the movements for brief periods only. The patient has suffered a vascular insult affecting. Now, the movement that they're talking about are the violent flinging involuntary movements of the upper limb. Now, we know that this is the condition known as hemibolismus, and hemibolismus typically occurs due to hemorrhagic insult of the region of subthalamic nucleus. Then comes the scenario in which there is a 47-year-old banker and he exhibits a personality change over a course of a few weeks. He has jerky movements when trying to pick up a cup of coffee or hold a pen to write. The patient's wife recalls the patient's mother died in her 60s of a progressive illness that started like her husband's. CT imaging reveals apparent degeneration of a neural structure situated medial to the anterior limb of the internal capsule, which normally protrudes into the lateral ventricle. Now, the affected structure in this patient is, if you recall the MRI scans that I showed you, we see that the structure which is lying on the medial aspect of the anterior limb of internal capsule is the caudate nucleus, the head of the caudate. And these symptoms are typically the jerky movements when the patient is trying to perform, you can see any activity, or it can be there at rest. When we talk about such movements, we usually consider them as to be chorea. And you know that Huntington's chorea is the hyperkinetic disturbance in which the part of the brain which has been affected is the striatum, that is mainly the caudate nucleus. So answer A is the one which is the answer to this question. Okay, so this concludes with today's discussion of basal nuclei, in which we covered the basic anatomy, the connections and functions of the basal nuclei, and we also looked at these masses of gray matter in a three-dimensional model and discussed some clinical scenarios at the end. So if you found this presentation helpful, kindly like and subscribe to my YouTube channel, which is AnatomyMentor. You can do that by simply pressing on my picture, which is going to appear at the end of this video. Thank you for your time. Until we meet next time, take care and Allah Hafiz.